Hello, my name is Jenny R. Smith, and I'll be discussing the voyeuristic disorder. Before we begin, I'll be going over the objectives of this presentation. So we'll be discussing the diagnostic criteria, the development and course of the disorder, the prevalence and prognosis rate, cultural consideration, differential diagnosis, treatment options that are available, the assessment that we might use, history of voyeuristic disorder, current research, and example of a case study. For this slide, we'll be discussing the diagnostic criteria for the disorder. So to match the criteria, the disorder or the symptoms must be occurring for at least a period of 6 months, as be recurrent and intense sexual arousal from observing an unsuspected person who is either naked, in the process of disrobing, or is engaging in a sexual activity, which then will manifest a fantasy or urges or behaviors that they may or may not act upon. Additionally, this individual has acted on these sexual urges with a non-consenting person, or these sexual urges or fantasies cause clinically significant distress or impairment. And for the third criteria, the person has to be at least 18 years of age. Just so everybody's aware, voyeuristic disorder is a type of paraphilic disorder, which is based on a perceived deviation that is an inappropriate ideal of sexual norms. Voyeurism in itself isn't a disorder, but when a person becomes consumed by voyeuristic thoughts that they become distressed, unable to function, or they act on the urges with a person who hasn't given their consent, then it becomes a disorder. To determine the progress of the person who has this disorder, we have to consider two environments. The first is in a controlled environment, which is where it's applicable to individuals who are living in an institution or setting, where opportunities to engage in such behaviors are restricted, or in full remission. This is where the individual has not acted on urges with a non-consenting individual, and there has been no distress or impairment for at least 5 years. And in the in full remission specifier, it does not address the continued presence or absence of voyeurism, which may still be present after behaviors and distress are remitted, which is just saying that even though there's no more behaviors or distress, the person still may be experiencing the feelings of intense desires or acts to witness people who are in the act of undressing or engaging in sexual activity. For the development course, the first is that adult males often first become aware of their sexual interests in secretly watching unsuspecting persons during their adolescent years, which follows into why we can't diagnose a person with voyeuristic disorder until they're 18, because it's very difficult to differentiate the age-appropriate puberty where males are finally reaching that age and they're becoming more curious, and the sexual curiosity activity may overlap with the disorder. Third, the persistency of the disorder over time is unclear. The intensity and the behaviors that are acted upon. The disorder requires one or more contributing factors that may change over time with or without treatment, which include subjective distress, psychiatric morbidity, hypersexuality, and sexual impulsivity, psychosocial impairment, and/or propensity to spy on unsuspecting naked or sexually active persons. And then the course of the disorder may vary by age. As I've stated before, people may display voyeurism behavior, but that does not dictate them being diagnosed with a voyeuristic disorder. However, with the prevalence and prognosis rate, voyeurism is a necessary precondition that increases the risk factor of developing the voyeuristic disorder. However, we don't know the relationship to voyeurism. It is still uncertain and the specifics are unclear, but the risk factors do include childhood sexual abuse, substance misuse, and sexual preoccupation hypersexuality have been suggested as risk factors. However, as such, it's still uncertain as to which has a higher rate of the increased risk of developing the voyeuristic disorder. And then the prevalence rate in the population is still unknown, but in a non-clinical sample, the possible prevalence for this disorder is 12% in males and 4% in females. In regards to cultural consideration, we have to consider childhood upbringing, such as the chance of a person having went through a childhood trauma, religious or political beliefs, in regards to the beliefs and stigmas of a person seeking or not seeking treatment. Gender, as we've been shown, there's a 3-to-1 ratio from male to female who is at increased risk of developing this disorder. And then risk factors of developing voyeurism, such as comorbidities with other disorders or mental health diagnosis. Other differential diagnoses that could be considered would be conduct disorder and antisocial personality disorder. The differential diagnosis would be characterized more by the additional norm breaking and or antisocial behaviors. Thus, the specifics of sexual interests and watching unsuspecting persons engaging in sexual activities would be lacking. Additionally, the substance use disorder, the differential diagnosis might experience voyeuristic episodes when intoxicated. So it's not their normal behavior to partake in such activities as watching a person being naked or engaging in sexual activities. When they're sober, that's not their norm, but when they are intoxicated or under the use, they may have recurrent voyeuristic sexual fantasies or urges or behaviors. To discuss treatment options, they can partake in psychotherapy, take SSRIs, or take anti-androgen drugs, or a mixture of the three. Um, in regards to psychotherapy, they can partake in cognitive therapy. It has been shown to help a person explore the root cause of their behaviors and help them realize that some of the behavior changes may need to occur. For SSRIs, it's been shown that Prozac or Lexapro can help be effective in the treatment of voyeuristic disorder by helping to suppress impulsive behaviors. Alternatively, drugs that reduce testosterone could also be used to treat this condition. A reduction in one's testosterone levels could cause a reduction in their sex drive, which may help suppress voyeuristic urges. When partaking in the assessments, we have a few options. We can conduct detailed interviews, talk to their family and friends, do a physical assessment, view past medical records, because if the person can't be officially diagnosed until they're at least 18, they may have a history of seeking treatment, or investigate diagnostic criteria in the DSM. It's unfortunate because people with this condition are rarely ever diagnosed until they are caught committing sexual offenses as a result of their condition, or the impairment and distress to their everyday life is creating more distress and affecting their functioning. This is because they are unlikely to share their condition with a medical professional or a loved one. As we know, the prevalence rate is higher in males, and men, unfortunately, there's a belief in a stigma that they are less likely to seek help, which results in the condition becoming progressively worse before seeking help. Now to discuss the history of voyeuristic disorder. Voyeurs are a person who gains sexual pleasure from watching others when they are naked or engage in sexual activity, and they were actually well-paying whole lookers in brothels, which is a commercial innovation described as far back as 1857, but not gaining much notoriety until the 1880s, and not attracting formal medical forensic recognition until the early 1890s. In 1968, the DSM-2 finally expanded the range of sexual deviation to include voyeurism. Society has accepted the use of the term voyeur as a description of anyone who views the intimate lives of others, even outside of a sexual context. It allows a person to view the personal life of others from the outside. Additionally, one of the few historical theories on the causes of voyeurism comes from Freud and his psychoanalytic theory. The theory proposes that voyeurism is a result from a failure to accept castration anxiety, which castration anxiety is that a child has a fear of being damaged done to their genitals by the parent of the same sex, either the father or the mother, as a punishment for sexual feelings toward the parent of the opposite sex. So the son having feelings for his mom and then fearing for his father damaging his genitals. Castration anxiety could be linked regarding the idea that the individual does not recognize that their sexual desires may be the cause of their emotional distress. And then for some fun facts, on the legal aspect, in the United Kingdom, the voyeurism actually became a criminal offense in 2004. In a more recent English case in 2020, the Court of Appeal upheld the conviction of Tony Richards after Richards sought to have 2 voyeurism charges under the Sexual Offences Act dismissed on the grounds that he had committed no crime. According to the article, Richards secretly videotaped himself having sex with 2 women who had consented to have sex in return for money, but had not agreed to be captured on camera. In Canada, voyeurism was not a crime when the case Frey versus Vederok et al. Arose in 1947. In that case, in 1950, the Supreme Court of Canada held that courts could not criminalize voyeurism by classifying it as a breach of the peace. On November 1st, 2005, this was done when Section 162 was added to the Canadian Criminal Code, declaring voyeurism to be a sexual offense when it violates a reasonable expectation of privacy. In the United States, video voyeurism is an offense in only 12 states. That one actually surprised me. It may require the convicted person to register as a sex offender. The original case that led to the criminalization of voyeurism has been made into a television movie called Video Voyeur and documents the criminalization of secret photography. And lastly, Saudi Arabia has actually banned the sale of camera phones nationwide in April of 2004, but reversed the ban in December 2004. Some countries such as South Korea and Japan require all camera phones sold in their country to make a clearly audible sound whenever a picture is being taken. For current research, comorbidities in the disorder is based on research with males suspected of or convicted for acts involving the secret watching of unsuspecting nude or sexually active persons. So they are looking into further conditions that occur comorbidly with voyeuristic disorder, which include hypersexuality and other paraphilic disorders, particularly exhibitionist disorder. Additionally, depressive, bipolar anxiety and substance use disorder, ADHD, conduct disorder, and antisocial personality are also frequent comorbid conditions, which we learned a few slides ago, that substance use, conduct disorder, and antisocial personality were already differential diagnoses that could be used. And for the next part, viewing sexually explicit pictures and shows, now widely available and private on the internet, is not considered voyeurism because it lacks the element of secret observation, which is the hallmark of voyeurism. And the identifying piece that I learned after reading the MSD Manual Professional Edition was that it's the secret observation, and if the observation isn't secret and if the person isn't unsuspecting, it wouldn't be considered voyeurism. For the last part, it has been examined whether sex drive explains the sex differences in the frequency of engagements in the paraphilic behaviors. So the effects of sex drive and the interests and behaviors, there's an article that explains that sex drive explains the sex differences in the frequency of engagement in paraphilic behaviors. So the article was suggesting that the higher a person's sex drive, the higher risk that they may develop or be diagnosed with voyeuristic disorder. And this part is not on this slide, however, I found it as an interesting read. The article is called Juvenile Sexual Offenses in the Histories of Adult Rapists and Child Molesters, which was published in 1983. The link will be on the works cited slide that will be coming up soon. The results of the study revealed that a significant number of offenders manifest a history of sexually inappropriate behaviors beginning in early adolescence. It appears from the study that many offenders begin to act out sexually at an early age, and if left untreated, may escalate to more serious sexual assaults. This slide gives an example of a case study that may be experienced in real life. So Mark is a 22-year-old heterosexual Caucasian male who lives alone. Mark has recently sought counseling services due to feelings of distress. After further assessment, Mark disclosed that he's been feeling guilty and shameful of his obsession with watching unsuspecting people naked, and or engaging in sexual activity. Mark reports that he's been secretly watching people perform sexual activity since he was 13 years old. He reports that when he watches people, he develops sexual urges and will fantasize about the incidences. He reports that he may go back to watch the same person 2 to 3 times. He disclosed that when he was 10 years old, he was sexually abused by his uncle. He reports that recently he's been having fantasies watching unsuspecting people perform sexual activities, that he will not leave his house, and he keeps his curtains in his home closed. Mark reports that when he was 17 years old, his family took him to get assessed, but was informed he was too young to be diagnosed. So for the case breakdown, we can see that his symptoms have been occurring for at least 6 months. He displays recurrent and intense sexual arousal from observing unsuspecting person who is naked or engaged in a sexual activity. He's at least 18 years old. He has acted on the sexual urges with the person who hasn't given their consent. He has declared feelings of distress, of obsession, guilt, and shame. He's experienced childhood trauma. Even though we know that the prevalence and prognosis rate is unknown, it is still a risk factor that has to be considered. And he has recurrently spied on unsuspecting people multiple times. Here's a list of my works cited and a couple of my recommended readings that I've mentioned in previous slides. Lastly, for the discussion question, while there is no proven cause, possible risk factors include childhood sexual abuse, substance abuse, having preoccupation with sexual activity, and being hypersexual. Which of these risk factors would you consider to be the highest risk? Thank you for listening and watching my presentation, and I hope you guys enjoy the rest of your semester.